Hi, thank you all for being here today. And I echo what Ivana said about a wonderful session, networking session and sessions this morning. So a big thank you to our local hosts in Canada. I have my maple leaf flag here to say go Canada, and thank you guys. I'm really excited to be here today, both as a representative of World Eye Cancer Hope, as well as a retinoblastoma survivor. I was diagnosed at 17 months with bilateral RB and had my left eye removed at 23 months. I continued to have tumor growth in the right eye for 5 more years. And by the time I was cured at age 12, I had had 50 surgeries related to retinoblastoma. And I know that, none of this existed, social media, child life, survivorship sessions. And so it's been so important to me and to my mom and to my support group to have a community. And so through this one Retinoblastoma World Conference, I was in the one in Dublin and in Washington, D.C., and now here in Ottawa. It's really fostered a wonderful and beautiful community. 2 years ago, I unfortunately lost the majority of the vision that I had in my right eye. So it's been a very long road over the last couple of years, adapting to being legally blind in both eyes. I'm very thankful for the small amount of vision that I do have. And so it's made me even more committed to advocacy for retinoblastoma, education, research, and really fostering this survivorship community. So thank you all for being here today. I'm going to do a quick intro of our amazing panelists. First up, we have David Fryer from Children's Hospital Los Angeles. He's the director of the Life Cancer Survivorship Program at USC Norris Comprehensive Cancer Center and Children's Hospital Los Angeles. And he's a Trojan, so fight on, had to throw that in there. And he will be speaking about cancer survivorship programs as well as secondary cancer screenings. And then after that, we have unilateral retinoblastoma survivor, Cleonia Colbert-Dorsey from Maryland. And she'll be speaking about her unique RB journey, as well as finding a retinoblastoma community as an adult from the One RB conference in Washington, D.C. And then finally, we have our Canadian on the panel, Matthew Milne, who is a board certified ocularist and is based in Toronto. And many of you survivors and parents might know him as he does take care of a lot of patients from the Toronto area. So we will go ahead and get started with my presentation. As I mentioned, my talk is going to be about navigating the post-retinoblastoma adult journey. So we'll get started here. I have assembled some tips and tricks that I have found to be very helpful for me along the way, and that I hope will be helpful for our adult survivors in the group, also for our medical professionals. But if you're a parent and you have a young child, a newly diagnosed child, or a teenager, I hope that you're able to find some of these tips helpful as you move into the future. So my first suggestion is to find your tribe. I found that it's so important to have a support group, whether it's family members, siblings, members from your church, from Facebook support groups. You're going to meet so many people just today in these networking sessions, and they can be part of your tribe. Because when you have a group of people that you can lean on, that you can cry to, that you can ask for help, that you can know they'll ask you good questions, and they don't even need to really know that much about retinoblastoma or about cancer. It's just about being able to lean on your friends and your family. And on this slide, I have a photo of myself at age 4 at age 3 with my mom in Tahiti, and we're both smiling at the camera. And part of my tribe as an adult is really led by my mom, and I'm going to move on so I don't cry. Okay, get your social game on. Research RB and adult cancer survivor groups on Facebook, Instagram, Twitter. There are so many different groups. Many of you are already on a lot of these Facebook groups. I think I'm a member of like 12 different retinoblastoma Facebook groups. We have groups that are divided up geographically, groups that are for families, groups that are for moms, dads, adults, groups that are for prosthetic eyewears. There are so many different support groups out there. And with a little digging, you can find literally a group that's tailored to you. Once you join a group, introduce yourself, share your story, let folks know questions that you have. If you would like to interact more with a specific person in the group, send them a private message or a direct message, and then COVID permitting, organize a geographic, a regional get together here in Southern California. We've hosted 3 Southern California family days. The first 2 were in person, and this last one in August was virtual, and we were able to incorporate our friends from Northern California as well. But we've really created this community and this family here in Southern California, which has been really wonderful. In the networking session, I was in a session with Jeannie, one of the people that we met through our family day. Okay, assemble your medical A-team. Make a list of your annual appointments and schedule for the year. Develop a visit timeline with your ophthalmologist, oncologist, and ocularist to stay on top of your eye, socket, and prosthetic care. Enroll in a life cancer shift survivorship program, which David will be speaking about next. But I would like to also mention that I've been a part of a life cancer survivorship program at USC Norris Comprehensive Cancer Center for, oh my gosh, I don't know, 5 or 6 years now. And it's been really, really informative to help me learn about, secondary cancer risks and to really become my own advocate. And as I mentioned, you'll be hearing a little more about this in a few minutes. Part of what you'll learn in a life survivorship program is about genetic testing. So I really encourage you to consider genetic testing. It allows a scientist to isolate the gene mutation in your DNA. And once your mutation has been isolated, the geneticist can speak to you about your specific mutation. You can find out if you carry a heritable form of RB. And if you do carry a heritable form of RB, your risks for second primary cancers and more depending on your results. A specific example from my life is that I have a heritable RB1 mutation. And so not only did my genetics team, but also my life cancer survivorship team has discussed the various risks that come along with that mutation, one of them being melanoma. So they let me know the importance of seeing a dermatologist twice a year. And then with the dermatologist, we discussed, sunscreen, avoiding the sun, making sure to feel for lumps and bumps or discolored freckles, and to call, send photos, or ask questions. If you have low vision or no vision, it's really important to enlist a friend or a family member to help you do this. But that's just one example of how you can be more prepared knowing your genetics. I know it's quite overwhelming to learn that you might be at a higher risk for a second cancer after you've already dealt with retinoblastoma, but I have found that having a preventative plan, such as knowing I need to go to the dermatologist and knowing what to look out for, really helps kind of keep it at bay and keep my mind more calm. Stay healthy. This is one of those things that is so much easier said than done. It's so easy to say, eat well and exercise, but it is really important to cancer survivors to maintain a healthy weight and a lot of aerobic activity to stay your best. Try new sports or fitness classes online or on YouTube for free, like Pilates, self-defense, or salsa dancing. There's so many different things out there right now that are free with COVID that you could, search for any type of a sport or an activity, something that gets your heart rate up. Get friends involved in your fitness regime. Take weekly socially distant walks. Go to exercise classes in a park or start a fitness challenge with the group to hold each other accountable. I personally have 2 friends that we go on weekly socially distant walks, and it's great because we get to catch up safely wearing masks, but we also get to get some cardio in. Take care of yourself. Find time to step away from work, your phone, computer, electronics, and just relax. Again, easier said than done. Schedule weekly or daily times to do something that helps you unwind, like yoga, meditation, listening to a funny podcast, starting a new series on Netflix, something that just lets you chill. Mind your mental health. Consider going to a therapist to seek confidential and non-biased advice for dealing with life's challenges, and those that accompany being an adult cancer survivor. My last tip, which is probably my most, if there's one thing I would like you to take away from this, is to be your own advocate. And in our psychosocial panel, Natalia touched on a lot of these topics about being responsible for yourself and educating people. As she mentioned, sometimes doctors don't know very much about retinoblastoma, and you are the one that needs to share with medical professionals. You are the only person in charge of your adult survivorship journey. It's up to you to take control of your medical appointments and properly follow up with any medical concerns. Make your medical team your allies. This is probably the single most important thing that I've ever done as a retinoblastoma adult survivor. I have a million doctors. I have, a wonderful team at USC and a wonderful team at UCLA, and they talk to each other. When one ophthalmologist needs to talk to my ocular oncologist, they pick up the phone, they send an email, and they're all on the same side. One story that I do like to tell about making your medical team your allies is an example of my ocularist, and you'll hear more from our ocularist on the panel. But I used to absolutely hate going to the ocularist because it was so painful to take my eye in and out, especially multiple times. And I've been with the same ocularist Stephen had at, hi Steve, for, oh my gosh, over 20 years now. And as I became a teenager, as I matured, I stopped dreading it so much because I actually really liked Steve and his team and everyone that works in the office. And now, even though, yes, it is still painful, I'll take 2 Advil in the car ride up there, and my mom and I actually really look forward to going to the office because we know everyone and want to hear what everyone's up to, and it's like a little family reunion. And I've had multiple eye socket, eyelid, and facial reconstructive surgeries, and my ocularist has played such a vital role in, the post-surgery formation of the prosthetic eye, the shape of the socket, having to make, remake, tweak eyes so many times. And so really having my ocularist on my team, speaking to the surgeons and having everyone on my side has been so important. I don't even look at them as medical professionals or doctors. I just look at them as people that are my team members. My last piece of advice here is to ask for help when you need it. This was an incredibly difficult thing for me to do as a teenager and as a child. I didn't want anyone to know if I couldn't read something. As I became older, and now as I have more significant vision challenges, I think my friends are like, stop asking for help. You're always asking me to do something, obviously to read things, to have car rides, but really it is empowering. And as Natalia said, you need to be able to speak your mind, and you need to be able to let people know how they can help you, because 9 times out of 10, people are really willing and able to help you. Your friends, your medical professionals. I've been at Disneyland with my walking cane, standing waiting for someone, and just a random stranger will come up and say, do you need any help? Do you need help getting to the restroom? And it's so wonderful just to see that people really are kind. So in conclusion, being an adult retinoblastoma survivor is a lifelong journey, and one that's easier to navigate with the support of loved ones, a team of medical professionals who are your allies, and a positive outlook on life. And I have a photo here of a group from the One Retinoblastoma World Conference in Washington, D.C. in 2017. So thank you very much. And I would like to now turn it over to David Fryer, who, as I mentioned, is the director of the Life Survivorship Program at USC Norris and at Children's Hospital Los Angeles, and just happens to be part of my medical team and one of my allies. So with that, I'd like to turn it over to David.
Well, I've been asked to give this presentation on survivorship care after retinoblastoma, and I'd like to start by thanking Marissa, who was the most direct inviter for me to present, but also for all of the planners for this conference, for this session in particular. It's really a privilege to again be part of this, having been in attendance at the conference in Washington, and now virtually with this one. So thank you again for the great honor of being part of this. So what I'd like to begin with is actually the answer. This will be very similar to the last slide of the presentation, which is what's the bottom line? Why is it important for survivors of retinoblastoma and indeed all types of cancer to attend a survivorship clinic? Part of it is that as far as who should be referred, really it's any child or adult who has been treated for retinoblastoma. And why refer? Because there are a number of important functions of survivorship clinics that we'll be going through one by one individually, one of them being to monitor the health that's related to the cancer, the genetic status, and also prior cancer treatment, to receive treatment for any problems that do develop, to be informed about health risks and how to stay well, and then finally to access psychosocial support and resources. So what is cancer survivorship, first of all? I think the first part of this question is, who is a cancer survivor? And as many of you are probably aware, the National Coalition for Cancer Survivorship and the Office of Cancer Survivorship at the NCI has defined a cancer survivor in a sort of philosophical sense as really that anybody who's been dealing with the diagnosis of cancer from the time of diagnosis onward. So whether a person is on or off treatment, whether a person is considered cured or relapsed, but if the person is dealing with cancer or has been affected by cancer, that individual is by definition a cancer survivor. In a more pragmatic sense, for those of us who treat, medically speaking, survivors of cancer, we tend to think of this as somebody who has completed cancer treatment, and those are the individuals who need post-treatment care. What is cancer survivorship? Very broadly defined. It's activities related to the care of cancer patients aimed at maximizing their physical and emotional health and quality of life. So really, cancer survivorship is not about finding new problems. It's not about making life more complicated, but rather it's all about maximizing function, maximizing comfort, and maximizing quality of life. That's cancer survivorship, and it's a partnership between the medical team, the patient, and all of the patient's caregivers. What are cancer survivorship clinics and what are they for? Well, first of all, a cancer survivorship is focused on the needs of cancer survivors. That's why these clinics are developed and exist. What are the components of that? Part of it is monitoring for side effects after treatment, for sure. That's one of the issues that needs to be considered. But it's also about educating around health risks, which is something that's very important for individuals who may have a genetic susceptibility to cancer, like some retinoblastoma patients do, and also the prevention of those problems. And then very importantly, addressing the emotional development, informational and financial challenges that face individuals who have been through cancer treatment. Those who staff the cancer survivorship clinics are a multidisciplinary team that consists of a physician, very frequently an advanced practice provider like a nurse practitioner or physician assistant who specializes in cancer survivorship care, very typically a social worker who's able to provide information about sources, about resources and other benefits for individuals, and then finally other professionals in the case of retinoblastoma, ocularists and other therapists of many different types. But what they all have in common, or what we all have in common, is a shared expertise, a focus, a passion for cancer survivorship and for helping individuals who have been through this to live the very best lives that they can. Now, there are four major areas of function that cancer survivorship clinics try to serve in, and I'm going to go through each one of those here. The first being systematic medical monitoring and management. Now, I'm going to hit next, and a long laundry list of issues are going to pop up here. And I don't want to get lost in these too much, but just keep in mind that what all these have to do with is the medical health of the individual and managing those issues. So certainly for somebody who may have vision challenges, doing our very best to ensure optimal vision, working with ophthalmology, and then with the prosthesis fit and function with the ocularist is a key function. But there are some kinds of side effects that can occur after retinoblastoma therapy that can include hearing loss, peripheral neuropathy, or sort of a pins and needles sensory problem, or numbness in the fingers and the feet. In rare cases, heart issues. Those are important to screen for and to be aware of how to prevent. Ensuring that RB gene testing has been completed and that it's interpretable is very important. Most of our patients come from Children's Hospital, where there's a strong retinoblastoma program, and most of our patients internally have already had this testing, but not always. And sometimes we do have patients who come from other programs where this may need to be updated, using the most modern approaches. Monitoring for second malignancies, reinforcing the genetic counseling that individuals may have received. And then finally, something very important for retinoblastoma and other heritable conditions is assessing other family members who may be at risk. So these are all some of the different monitoring and management issues that fall under the medical category. A very important category, a second one, is psychosocial support. And I think Marissa's done a really marvelous job of already speaking to some of these issues. But these include helping individuals adapt, screening for their adaptation. This is especially important for young children, learning how to deal with vision difficulties and functional differences. And of course, they change over time as an individual grows older. Supporting the child and the parent with anticipatory guidance, arranging for psychology evaluations where needed, ensuring school accommodations are satisfactory, and then helping to connect patients and families with others who are struggling with some of the same issues, and with general cancer survivorship advocacy and support groups. So we may not be the experts in the psychosocial support, but we believe strongly in it and do all that we can to help connect our patients with the right kinds of advocacy groups and peer support. The third major area is health information and promotion, and this is a very important one. We work really hard at trying to have our patients more and more as they grow older and more mature and able to understand, to have an understanding of the risks for late effects, and along with that, opportunities for risk reduction. So for example, earlier I mentioned hearing loss and peripheral neuropathy. There are some things that either can be avoided or instituted early that can help with some of those problems. If an individual is at risk for heart problems, certainly there are some risk reduction factors like exercise, maintaining weight, and eating healthy, and controlling diabetes, those kinds of things that can be very, very important and done as a result of being informed. Second, malignancy prevention and screening. Marissa talked about that with melanoma. This is a theme that we do stress, sunscreen and avoiding smoking, other kinds of ionizing radiation that's unnecessary, trying to reduce this risk of second cancers. And then finally, a whole host of general health issues, which are not only good for physical health, but also for emotional balance and well-being as well. And then finally, the area of financial challenges, both current and future. In this case, we're really trying to plan for lifelong survivorship care. And there's something very important that I like to refer to as the golden triangle of cancer survivorship, which applies at least in the United States, where given our particular health insurance system. And it's the 3 points of what I call the golden triangle: education, employment, and health insurance. These three ingredients are crucial for obtaining health insurance, at least in the United States systems where most individuals are still insured through private means. So what do these each mean? One is education, is completing education, including job training, to be able to have the training and the credentials to get then the second point of the triangle, which is a good job, meaning a job with benefits, with health benefits. And then finally using that to leveraging that job with benefits to obtain good quality health insurance. Now, this is not easy in the United States, even for those of us who work in healthcare. It's a real challenge trying to navigate all of this, but that's what social workers are for, and that's one of the important functions that we carry out in our clinic as well, is to help these young individuals sort of navigate what can be a very tricky and complicated system. Now, another point that's important for survivors of retinoblastoma, and indeed all types of childhood cancer, is the fact that individuals grow out of childhood and into young adulthood, and that requires transferring survivorship care from a child-oriented setting or pediatric hospital to adult-focused providers. And what this does is it ensures that our patients, whether they're children or adults, that they receive the lifelong care that they need, that's both medically appropriate, but also age appropriate. So when a child is 7, 8, 10 years old, certainly a children's hospital is a very good place to be. But when a person turns 21, 25, 30, that's an adult, and adults develop adult problems and need adult providers. So the ideal way to do this, and something that patients and caregivers can kind of keep their radar up for, is a transition program, which helps them navigate that switch from a pediatric program to an adult provider. Preparing for transitions should start early as 13 to 15 years of age, with plenty of time in advance to identify healthcare partners, working with the treatment team, having what's called a survivorship care plan. Very important component of transition care and survivorship care is receiving a record of all of the treatment that the patient received, all the chemotherapy, all the surgical procedures, all 50 of them that Marissa mentioned, ideally would be spelled out and clearly obtainable for the survivor to have access to, no matter where that individual goes for care. Considering the insurance plan that's in place from the time of older adolescence into young adulthood, and then being aware, and then having the patient family be aware of knowing what they need to have in the way of medical care. So I'll take just a moment as I wind down here to give one very specific example of survivorship care. This is just a quick snapshot of our program at Children's Hospital Los Angeles and USC. It's our way of doing what we believe in, which is to provide a transitional care program, but it's not the only way to do it. And certainly no matter where you are, transition of care is an important component and is something that can be provided. So care begins at our Life Clinic at Children's Hospital Los Angeles when survivors of retinoblastoma are referred by their primary oncologist within 2 years of ending treatment. In our survivorship clinic, they undergo a comprehensive survivorship assessment and then are followed once a year in parallel with the oncology team, the ophthalmology team, the ocularist, and so forth. None of that is given up to be in the survivorship care. Indeed, it's enhanced and supplemented. At 21 years of age is when our program transitions our now young adult patients to adult-focused providers. For those who are considered to be at higher risk by certain criteria in our program, which include having been exposed to previous radiation treatments, certain kinds of chemotherapy, such as what we call alkylator chemotherapy, cyclophosphamide, or anthracycline chemotherapy, doxorubicin, for example, which place the body at different kinds of risks, and or those individuals have a germline mutation of the RB1 gene. Those individuals are considered to be at somewhat higher risk for health problems and therefore merit the intensity of a specialized survivorship program for adults, which we offer over at the Norris Comprehensive Cancer Center. So our patients then who are in this higher risk category transition over to us, and we continue to follow them. For those who are at lower risk, which basically is all of the other survivors, including most unilateral retinoblastoma patients who have been treated with what I'll call minimal types of cancer treatments, they're transitioned actually to primary care to try to provide a more normal, wellness-oriented sort of environment for continued follow-up and try to unplug and get off the, the pathway of high-intensity medical care. Try to normalize life a little bit. That's our philosophy there. It is important that they do receive follow-up and a survivorship care plan is provided, but again, they do that in the context of their primary care office. So that's our way of doing it. Just to recap quickly and to stay on time, I'll end where I started, which was just a quick 5-question and response to what this presentation has been about. Who should be seen in a cancer survivorship clinic? Any child or adult who's been treated for retinoblastoma. Why? To get access to optimal comprehensive survivorship care. When? Soon after treatment's been completed and continued on lifelong. Where? If available, a survivorship clinic. And there are websites that list these all around North America. So, you can gain access, and I'm sure that in other countries, they're also available, perhaps not through this particular link, but through other links in your country. And then for how long? Again, lifelong, at least for high-risk patients. So with that, I'll end my presentation and thank you again for the privilege of being able to present, and I'll go ahead and stop sharing my slides.
Thank you so much, David. Now you all can see why I feel like I'm in excellent hands at the Life Survivorship program at USC, because David and his team are so knowledgeable, and being in that high-risk category he was speaking about, they keep me informed and have really been an integral part of my adult survivorship journey. So thank you so much. Our next speaker is a unilateral RB survivor from Maryland, who, as I mentioned, I met at the 1RB World Conference in 2017. She is a force of nature and someone I am so thankful to call a friend and a sister in RB survivorship, Cleonia.
Good afternoon, everyone. Thank you to Marissa. Thank you to the Canadian group for organizing this weekend's conference. To our fellow panelists, I am just honored to be able to have this opportunity to share with you this morning, this evening, this afternoon, depending upon where you are in this wide, wonderful world of ours. It was a pleasure in 2017, when not only was I able to meet Marissa, but so many people who are probably, some of whom are on the call, folks who I made linkages with at that time in 2017 and have truly become my family. I look at those of us who have had to undergo the journey of retinoblastoma as being special, and by our shared challenges and our shared journey. Marissa spoke earlier to finding a tribe. Each and every one of you is in fact my tribe. And I was not able to truly walk in what it meant to be a retinoblastoma survivor until I had opportunity to meet with people who were like me, people who had undergone the same experience that I had gone through, as well as health advocates and allies who were very familiar with sort of the struggles that I had had to endure in life, the heartaches, the pains, but as well as the joy, the opportunity to be able to engage with that common tribe, that common family in 2017 was instrumental in my right now being able to own the fact that I am a retinoblastoma survivor. I spent more than half of my life trying to deny the fact that that in fact was who I am, a retinoblastoma survivor, that makes me the woman that I am today. So although I'm disappointed that we are not able to gather together in Canada, I look forward to when we are able to gather together again as a family and to give each other hugs and to have some happy hour moments together. You got to come to a conference in person to see what that actually is all about. But in the limited time that I have, and I could speak on and on forever, I just want to talk about my journey. So as Marissa has already shared, I am a unilateral retinoblastoma survivor. I was diagnosed, I hate to admit it, because then that tells you how old I am, but back in the 60s. So I'm in my 50s. Even though my kids try to tell me, no, mom, that's not what it is. I say that 50 is a new 40. So, hey, I'm going to play it that way. 50 is a new 40. I was diagnosed in the 60s. And I say to folks, and my family, my mom and my dad and my sister are actually listening on the phone because they can't figure out Zoom. So they couldn't get this to work out. So they're listening to me. They're about 2 hours away from me and they're listening to us. I like to say that my mother gave life to me twice. She birthed me, but then the fact that my retinoblastoma was diagnosed was because the fact that my mother knew her child. And because she knew her child, as I was growing, and I was approximately 2.5 years old, she looked at me and she looked at my eyes and she could tell that there was something different and there was something off. And she had to take me to a number of care providers before, in fact, she found someone who was able to make the diagnosis that, yes, your child has retinoblastoma and she needs to be treated right away. At the time that that diagnosis came, my mother, in fact, was pregnant with my sister, who's 2 years under, no, I'm sorry, was pregnant with my baby sister. Yes. My surgery was held in November at the Cleveland Clinic, and my sister was due in April. So my mother was wondering, can we wait until after I have this baby before the treatment needs to go forth with my older child? And she was told that if they would have waited, that I probably would not have survived. So my mother was an advocate. She persevered. Even though she was pregnant, she put that aside. My whole family just banded together so that I could get treated. And I think that that is one of the strong suits that allows me to be the woman that you see seated before you today. I have had tremendous family support in this journey during a time that was quite difficult. Being diagnosed in the 60s, in the time of civil rights, an African-American child, I was the only person in my family to have received the diagnosis of retinoblastoma. The interesting thing was, and I was in an article done with Abby White. Don't know if Abby's on the call. If you are, hi. But within that article, I shared the fact that when I was born, I had both great-grandparents as well as grandparents who were still alive. And I was fortunate that I got to engage in them. So you're talking of a span of 5, 6. When I was born, I was the 5th generation of living, breathing history in our family. And I was the first person to ever be diagnosed with retinoblastoma. That was a challenge. It was a challenge for my family. It was a challenge for me because there were no survivorship programs that we were aware of at that time. We had to undergo the journey as a family and try to figure it out for ourselves. That's why I think that the work that is going on right now is so critically important, to unite families, to bring families together, to have advocates and allies to help navigate what can be a difficult journey. For me, it was a difficult journey because I often wondered, why me? And I think that that's a question when you think that you're the only person in the world going through what it is that you're going through, you wonder, why me? So that was my struggle. Why me? The emotional side effects that come with that. The stories and the talks that I've had with my parents, wondering perhaps what it was as parents that they did or didn't do that caused their older child to be affected. To some degree, I have heartache by the fact that the resources available to families and survivors today, what makes us who we are, is not what was available to me when I was going through this, which leads me to what I want to share when it comes to self-image and self-confidence. When you look at me, I don't know what you see. I'm trying to look cute as I sit here. But I have developed an exterior to convey confidence, but inside that's not always something that I've held. I've always wondered, what do people look at when they see me? Do they see this strong, put together, polished woman, or do they look at me and do they see my battle scars? My battle scars come from the fact that I am a retinoblastoma survivor. And I am a strong woman because I came from a strong family who were determined not to let what their child was going through set her back. And so my family were probably my strongest supporters, my strongest cheerleaders. In fact, my grandfather was the Tuskegee Airman, and I say that he helped to be the wind beneath my wings. And then 50 years later, when I find this retinoblastoma community, when I find the resources that are on the internet, and I get to connect with Marissa and Sandra Stefarari, who you guys are going to hear later, and just everyone who I met in 2017 and everyone who I engage with in the RB community on Facebook, that caused me to be a new woman. That's when I began to own the fact of who I am, a retinoblastoma survivor. And anything that I can do with whatever time left that I have in this world is about owning the fact that I am a survivor. I can't forget the fact that I'm a cancer survivor. I think as RB survivors, that's one thing that makes us different. There are perhaps others who have gone through various cancer journeys, and perhaps they can get to a point where they forget about it in their lives. I think with us as RB survivors, every time I look in the mirror, am I out of my time? Okay. Every time I look in the mirror, I'm reminded of the fact that I had retinoblastoma and I survived retinoblastoma. But I'm here and I stand and I'm a woman. So in closing, because I've lost track of how much time I have, a mantra that I have developed is that life brings struggle, but struggle births hope.
Audio now unmuted.
The fact that those of us on here who are survivors are still standing, are still able to own our truth. I'm sure every one of us would agree that the journey has not been easy. It's been a struggle, but we're still standing, we're still surviving, and we're going to continue to do so because as we journey through life, we have hope for tomorrow and what it is. I thank you again for this opportunity. I look forward to connecting with each and every one of you. I'm on Facebook, I'm on LinkedIn, look me up. And if you're ever in the DC area, I'm only about 20 minutes outside of DC, please let me know. I would love to connect and engage. Thank you. Enjoy the rest of the conference.
Thank you so much, Clay. Now you all can understand why I said I'm thankful that she is my friend, and a shout out to Clay O'Neill's family and mama for being such amazing supporters and raising such a beautiful, beautiful woman. And you're making me cry because I love you so much.
I love you.
Okay. Now we're going to turn to Matthew Milne, our board certified ocularist from Toronto. Welcome, Matthew.
Hello, everyone. I just want to take this opportunity to thank the One Retinoblastoma World organizers, the We See Hope organization, and Marissa for asking me to speak today, and the Canadian Crab Research Association board. And I just want to say that I feel very honored to be able to speak along such amazing healthcare providers today and survivors of retinoblastoma. So my name is Matthew Milne. I'm an ocularist in Toronto, Canada. And I work alongside the Hospital for Sick Children and the RB team there. And today I'll be speaking about the role of the ocularist in the retinoblastoma patient journey. So the decision to enucleate an eye is an emotional and difficult one to make for all involved. For the parents, one of the primary questions is, how will I make my child look normal again? Involving the ocularist in this discussion can bring solutions and support to parents early in this journey. And the best outcome is when we partner with both the parents and the surgical team to develop a custom ocular prosthesis for their child. So at the completion of this process, parents often remark that they see their child whole again, giving the family a sense of normalcy after an incredibly challenging diagnosis. So the first thing I'd like to talk about is the relationship. So the relationship between the ocularist, the child, and the parents is one of the key parts of this entire process, and it should be based on open communication, respect, and trust. When meeting the family in the clinic for the first time, I always like to have the child play in the office to start off the appointment. Children de-stress through active play, and giving the child a opportunity to play in that space gives them a sense of familiarity to it. So I always provide games, toys, or drawing to create a level of comfort for all the new people in the room and to the space itself. And at the same time, it gives a great opportunity to answer any questions the parents and children have at the time. But I always want to stress that you have to speak to the child as well as the parents when answering any questions. They are the main person in this development. So here's a picture of the play area at my clinic. As you can see, I've had a lot of fun going out and getting toys for children to play with. Maybe I aged myself a little bit with the Star Wars potato head, but luckily it seems to have come back into fashion again lately. So how we first start out is a prosthetic fitting under anesthesia. And so we normally do that 6 weeks after the time of the enucleation. And we always recommend that this procedure be done for children up to 4 years old to account for any cooperation difficulties. Fitting a prosthesis under anesthesia allows me to examine the anophthalmic socket and allows for full cooperation for the fitting procedure, and it doesn't create any sort of discomfort for the patient during this process. What I do is I take an alginate impression of the socket to fully customize this artificial eye to the individual person. At the same time, I'll size the iris for accuracy and take any clinical notes of the socket dynamics. This time is a great opportunity to take a full look at the socket while the person's under anesthesia. And here's a picture of the fitting process that we do at Sick Kids Hospital for children. So the next step we'll be talking about is replicating the companion eye. The artificial eye should be color matched for both iris and scleral tinting. We then copy the vasculature and pigmentation. And I do this through both physical inspection and also photographic comparison. I always want to talk to the parents about the pupil dilation, what it is at home or at school, because what I see is only in one lighting environment in one situation. And after the fact, we can always make adjustments to account for any discrepancies in environments. And then what I always like to do as well is actually paint a picture on the superior portion of prosthesis. And this gives a child the opportunity to pick something for themselves and make it special. Through this process, children are made to do a lot of things. This is something that they get to pick from. Here's some pictures of eyes that I've done. Kevin from Minions was a big hit for a while. You see the drawings on top. And then here's another segment as well. At this time, I just want to say a big shout out to the Toronto Raptors, the 2019 World NBA Champions. So then we get into the fitting of a new prosthesis. So when it comes time to fit a prosthesis, it's important to explain the entire process to the family before we proceed. Answer any questions that they may have, and ask permission from the child itself, because they are the one who's allowing you to go ahead and do this process. I also want to involve the parents. So if they're comfortable, I like to have them practice in the office. This builds a level of confidence so that they can do it at home and know that they've done it in the past. If they're not comfortable at the first day, we work on it for multiple steps through multiple appointments. And then I always want to say, we want to acknowledge success. High fives, great jobs, way to goes, help build confidence for a child completing a new task. So here's the idea of fitting a new prosthesis. And as you can see from this diagram, children as young as 3 and 4 years old can be comfortable with the process if you walk them through the steps. So let's talk about results. So the primary goal of an ocular prosthesis is to give the patient confidence in their own appearance. The definition of a successful result is different for each individual. Perfection should never be the defined expectation. How our brains work is that we find differences when we know they exist. And we can't fool someone who knows it's a prosthesis. The way I like to define it is a successful goal is when someone who doesn't know can't tell that it's a prosthesis. And so here's some results. This is Avi. She's an unbelievable artist in her own respect. And she always likes to help me work on the artistry with the prosthesis and ask lots of questions. She's very interested in the whole process. This is Adavan. He has a great sense of humor, and him and his dad always joke around the office. It's a real pleasure to have him, both of them, in our clinic. Here's Nathan. Him and his brother love to play on the Nintendo Switch. They duel each other all day long when they're in the clinic. They're great friends. And this is William. I met him many years ago. He actually came over from England, and he's back in England again, so I don't see him anymore, but I hope he's doing well. I'm sure he's a lot bigger than he was in this photograph. So let's talk about regular appointment scheduling. So how I like to do it is do biannual appointments. This keeps the prosthesis fitting its very best. It also allows us to avoid or detect any complications before they can escalate. Children can't always articulate discomfort or irritation. So it's important to have the socket checked and fit for irritation by an ocularist, the medical healthcare team at the hospital, or the parents at home. And I like to say during these appointments, the prosthesis can be augmented or adjusted to fit the socket as the child grows. And finally, a person blinks roughly 10,000 times a day while they're awake. So polishing or reglazing a prosthesis on a regular basis allows the lid to glide over that prosthesis with as little friction as possible, minimizing discharge and any discomfort that it may inhibit. So let's get into socket complications and primarily socket infections. So signs of infections is something that many anatomic retinoblastoma survivors deal with is excess discharge, socket irritation, or discomfort. These infections can be viral or bacterial. And the first action a parent should take when discharge is present is to remove the prosthesis and look in the socket for any signs of irritation or foreign material. If nothing is seen, but there's still discharge, have a child take a shower. It's not necessarily time to head into the hospital. First, have them take a shower. Sometimes a foreign body or some sort of debris can be in the socket, and the shower allows the water to run comfortably through into the face, into the socket, and then clear anything that's in there. And then you can reinsert the prosthesis. And what I recommend is watching it for 3 days to see if there's any signs of improvement. If the socket continues to present with discharge, or if pain is present or starts to increase, book an appointment with your healthcare team for assessment and culture to figure out why that irritation has developed. And then the next step is implant exposure, something that we'd never want to see with an anophthalmic socket. So within the first year of enucleation, the risk of implant exposure is the greatest. This is because the socket is still healing. The healthcare team should be notified immediately if the child presents with any sort of pain, bloody discharge, or any extreme excess mucus discharge. So that if the socket is cake closed or drooping down or running down the face. If implant exposure is caught quick enough, conjunctival repairs can be made, a graft can be made if the exposure is small. Unfortunately, larger exposures may need to have the implant replaced. I'm very fortunate with the excellent surgical team at Sickens Hospital. We don't see a lot of implant exposures, but it is a possibility. I'd like to talk about tips and tools of the trade now. So regular at-home cleaning. So we believe that the prosthesis should be removed on a monthly basis for cleaning and inspection for children. When removing a child's prosthesis, it's good to find a time when there's no rush, so you're not rushing out for dinner or for school, and try and catch them in a positive mood. You also want to follow through if you're going to do it. If a child cries and tries to deflect the situation and you relent, it'll become a pattern. But that being said, if you become frustrated, take 20 minutes, try it again. Nothing is ever easy when you're flustered. And then finally, if a prosthesis turns, which is always a possibility, it doesn't need to be removed. You can simply turn the prosthesis using a suction cup. But if it happens on a regular basis, book an appointment with your ocularist for adjustment and modification. Here's a couple tools that we use in the office. These are a suction cup on the top picture here. This helps to remove a prosthesis. It especially helps with smaller children. Smaller socket with larger hands makes it difficult. These gives you control and purchase over the prosthesis. We also have these patches that we have. I use them in the office if we remove the prosthesis and the child is going out. I also recommend parents leave them as a kit for kids at school in case a prosthesis were happen to fall out. You can have a little packet with the patch and a suction cup so that if the eye does fall out, the teacher can put a patch on because it's not the responsibility to place it back in. The parents can come and visit the child at the school and the suction cup's already there. So there's no special trip to go home to fix it. So in conclusion, when a child eye is enucleated, one of the primary questions the parents has is, what will my child look like? And with successful surgery and a properly fitting prosthesis, the child can look like themselves again. When a custom ocular prosthesis is first inserted, a lot of the families will mark that they have their beautiful baby back again. And this is one small step in the healing journey that is the retinoblastoma journey. So I'd like to finish up saying that the Ocularist is an integral part of the patient's healthcare team and a resource for patients and the family that they can use for their entire lifetime. So I'd just like to say thank you again to the organization for allowing me to speak to everyone today. And I just think all these presentations have been great so far. Thank you very much.
Thank you so much, Matthew. That was incredibly informative, and you could not be more correct when saying that an ocularist is absolutely an integral role in a retinoblastoma survivor's journey. So thank you for all that you do for our kiddos in Toronto. Caitlin, do we have time for questions?
Yeah, we're due to start the next session now, but
Okay.
We'd like to do a few questions nonetheless. I hope everyone will be patient with us if we run just a few minutes behind, because questions are such an important part of this meeting. So I'll just jump into the first question. Someone has asked about a resource that was probably published about 25 years ago. It was a heat map characterizing some of the chance of second malignancies throughout life. And they wanted to know if any of the panelists knew if there was an updated version of this resource available.
David, we'll let you take that one.
Sure, I can answer that. Yeah, there actually have been updated figures published as recently as 2019 on, the spectrum of second cancers in retinoblastoma. Marissa, I don't know if there are ways that we can make those citations available to individuals. Maybe if they could contact you or somebody else, I'd be happy to provide that reference for the individual to get a hold of. I would say that in broad brush, the numbers and the types haven't changed dramatically, but what's changed is that the treatment of retinoblastoma has changed so much over the last 2 to 3 decades. Radiation is used very, very rarely anymore, if ever. And that's changed the complexion of second cancer. So if that's the last resource you have, I would say yes, get in touch with somebody. I'll be happy to provide a citation for something more recent.
We can post it on the website that has all the other presentations.
That's great. Thank you very much. Another question was asked, and I know obviously we have to be careful giving any medical advice without knowing a patient's full clinical history, but I didn't know if anyone wanted to comment on a question that was asking about hormone therapies such as people going through perimenopause, if there's any considerations for adult retinoblastoma survivors pertaining to that.
I'll be happy to take that one. In general, this question comes up quite a bit, about hormone exposures and development of cancer, either first cancers or recurrences or secondary cancers even. To my knowledge, in retinoblastoma per se, there hasn't been any, concern that I'm aware of that's been raised about that. I would say that the type of cancer where we have where the questions were the most intense was in brain tumors, and there was a period of time, a decade and a half or so ago, where there was intense scrutiny of this, because many brain tumor survivors have hormone deficiencies due to the cancer treatment that they had, and in particular, growth hormone deficiency is common and often needs to be replaced with growth hormone. So that was something that received a lot of careful analysis, and the final, verdict on that most recently appears to be that the risk is not greater for most patients receiving, hormone replacement therapy for brain tumors. Now, retinoblastoma is not a brain tumor exactly, and perimenopausal hormone therapy is not growth hormone. So there are some differences here, but I think in general, the information that we have is pretty reassuring.
Thank you. Another question for you as well was about, you talked a lot about survivorship strategies, and one of our audience members wanted to know how you recommend organizing that for a patient that has to travel a long distance to see their oncologist. And I might also add to that question if I could, because I know there's obviously people here from other contexts where survivorship programs and strategies aren't necessarily feasible. And so I didn't know if you could also comment on any resources you might recommend for folks that don't have access to a program such as yours.
Sure. I think there's a couple of options. First of all, it's a really great question, and you've hit on one of the big challenges of survivorship care, which is making it accessible to individuals. I think that, let me just say that as I speculate in the years ahead, I think that survivorship care is going to become more accessible, actually, thanks to the expansion of platforms like Zoom and other virtual platforms, where I think it's actually going to make it possible to access expert survivorship care without necessarily having to go for an in-person visit. So I would say stay tuned in this regard, and I think we can look forward to probably getting you more information in an easier, more personalized format. But until we're at that point, a couple of suggestions I would have. One is, if you are aware of where the nearest survivorship clinic is, even if it's a couple of hour drive from where you are, go ahead and consider going there. Survivorship care, generally speaking, I would say in most instances is a once a year proposition. It's not a frequent visit, and it can even be done with a one-time visit. If you have the means and capabilities, to get to a survivorship clinic where you can have a good, thorough going over, go over your records, get all of that pulled together for you so that you can leave with a nice summary of the treatment and, a good, thorough understanding of all the main issues. That will serve you very well. And I think if you can take that back to your primary care provider and work with that individual, that may help a great deal. If it's the second suggestion I would have, if it's not possible really to make a physical, trip there, consider reaching out to your nearest survivorship clinic. Email them, contact, call them, whatever. Let them know your situation and explain, your need for more information. We do get calls like that from individuals who are not necessarily from Los Angeles, who are from far away, and they do ask how we might be able to help. And it's not the same as having an in-person visit, but we can oftentimes do, quite a bit from a distance and help the person kind of get their questions answered and get on the right path to the help that they need.
Wonderful. Thanks for such a comprehensive answer. There's one last question, if I may, which is, I believe this also is for you, David. I think in your talk, you talked about emotional adaptation, and Genevieve was wondering how someone might screen for that and at what age that would be appropriate.
Sure. I think that to have a formal assessment, probably engaging a child psychologist is the way to go, and ideally somebody who is familiar with childhood cancer issues and cancer survivorship issues. I would say that a community-based child psychologist without that expertise can probably do an admirable job. But I think some of the subtleties are most apparent to psychologists, who work in the cancer setting. And so that would probably be considered, the gold standard. As far as, who should have that, I would say certainly if there are any, concerning signs that the child is not adapting well, either coming from the school or the parents' own observations, and it seems to be more than just you know, a transient phase that the child is going through, but it's something persistent. I would say err on the side of caution and go ahead and have that child evaluated. But again, you know, accessing a child psychologist, ideally with experience in childhood cancer issues, is probably the best way to go.
That's great. Thank you so much. And there was just another comment thanking Marissa and Cleonia for sharing their experiences. One of the attendees wanted to thank you so much for sharing that, and they appreciated your time. So thanks all of you, and Matthew too. That was a great session.
Thank you, everybody.